Okay, so we're going to start with basic physiology and just remind ourselves on the waves, intervals, and segments you will normally have on the ECG. So again, with basic electrophysiology, we want to remind ourselves that we have our dominant pacemaker of the heart, which is the SA node, which is always on the right atrium. So again, we're going to have the SA node. And when the SA node fires, you're going to have the impulse that's going to spread to the AV node. And from the AV node, the impulse is going to go down the right and left bundle branches, and then it's going to go into the Purkinje fibers. So again, we'll be talking about ECG today, and you want to remind yourself that our ECG machine records electrical activities in the heart, and it's going to have these positive and negative deflections according to how it records those electrical activities. So for example, if we have our P wave firing, the ECG is going to give you a positive deflection. So I'm not going to go into this, why it's positive and why it's negative, but I just want you to keep that at the back of your mind. So when the P wave, the SA node fires, you're going to have your first positive deflection, and that's our P wave. Again, your first positive deflection is your P wave. And then when the impulse gets to the AV node is going to hold the current for a while. And when the AV node holds the current for a while, it's going to give us our PR segment. So this portion where the ECG is not detecting any electrical flow of current because the AV node is holding the current, is going to go back to the isoelectric line. And then when the impulse is released from the AV node, when the impulse is released from the AV node, it's going to travel down the bundle branches, and then you're going to have your QRS complex. And the QRS complex represents ventricular depolarization. So remember, when the SA node fires, you're going to have your P wave, which represents atrial depolarization or atrial contraction. And then we said you're going to have your QRS complex, which represents ventricular depolarization. So this would be our Q wave, this would be our R wave, and this would be our S wave. And then you're going to have what we refer to as our ST segment. And this actually represents the time interval between depolarization and repolarization of the ventricle. So that's what your ST segment represents. So this portion that is on the isoelectric line is our ST segment. So that's our ST segment there. Remember, we said this was our PR. So this was our PR segment, this same flat isoelectric line. So that's our PR segment, is our ST segment, and after which you're going to have your T wave. So this is our T wave there. And again, what does the T wave represent? It represents ventricular repolarization. Again, that's the origin of all of those waves, segments. We're also going to talk about intervals. So let me take this off so I can see it a whole lot clearer. Okay, so there you have it. So again, we said first positive deflection is our P wave. So that's your first positive deflection. And then we said we get this as a result of the SA node firing, and it's going to cause mechanical. So is that electrical activity from the SA node is going to translate to mechanical contraction of the heart. And you're going to have your P wave. And we said the impulse, the current is going to go into the AV node. And we said because the AV node is going to hold the current for a little while, remember, you don't want the atrias and the ventricles contracting at the same time. So that's why the AV node is going to hold the current for a while to allow for complete emptying of the atria, allow for complete emptying of the contents of the atria into the ventricle. So when it holds the current within itself in the AV node, the ECG is not going to detect any movement of current. And as a result, the needle is going to go back on the isoelectric line. And we said this isoelectric line is what we refer to as our PR segment. So the P wave is your first positive deflection, and the PR segment represents the period which the AV node holds the current. And after that, we said we're going to have our QRS complex when the impulse goes from the AV node into the ventricles. And we said the QRS complex represents ventricular depolarization or ventricular contraction. And then we talked about the ST segment. So you can see the ST segment starts at the end of the S wave. So that's the end of the S wave to the beginning of the T wave. So that's our ST segment right there. And we said it represents the time between depolarization and repolarization of the ventricles. So again, for the Nclex, you will need to note that when we have ST segment elevation, so you can see now it's flat, it's on the isoelectric line. There are times where you might see it elevated. Again, for the Nclex, we said anytime we see ST segment elevation, it tells us this patient, or it might indicate a blockage of the coronary artery or a myocardial infarction. So you want to know that for the Nclex, when we see that the ST segment is elevated, it could indicate a complete blockage of the coronary artery, and it could also tell you this client might be having a myocardial infarction. You could also see the ST segment depressed, so it could also be depressed. So this time it's going below the isoelectric line. Again, what does that tell me? That could be an indicator that your clients may be having low potassium levels. So again, ST segment elevation, myocardial infarction. ST segment depression, possible hypokalemia in your patient. So again, look out for a depressed ST segment. Look out for the client's potassium level. Again, the Nclex may not tell you the client's potassium level is low, but they can go ahead and tell you that you did an ECG on the patient, and we are seeing that the ST segment is depressed. So again, that could tell you the client could be having a low potassium level. So that's for our segments. And then we said, okay, we're going to have your T wave. Again, we said the T wave represents ventricular repolarization. Remember, after depolarization, the muscles have to go back to those resting states, those negative resting states, so that they can be able to contract again. That's what your T wave represents. It represents ventricular repolarization. Again, you could also have intervals. So what are intervals? Again, intervals are made up of waves and segments. For example, if we add our P wave to our PR segment, we're going to have our PR interval. So if we start from the beginning of the P wave to the beginning of the Q wave, or okay, so the beginning of the Q wave, what we have in between there. So we're adding our P wave and our PR segment. So what we have there is our PR interval. Again, we'll look at what the duration of the PR interval should be, but that PR interval from here, from the beginning of the P wave to the beginning of the QRS complex, represents the time taken for electrical activity to move between the atria and the ventricle. So remember, all of this happening here is all happening within the atria. So again, that's what your PR interval represents. It represents the time taken for electrical activity to move between the atria and the ventricle. And most times it could be prolonged. So we'll talk about the duration, what it should be. But again, it could be prolonged. But I want you to remember this on the Nclex. If I see that there's PR prolongation on my ECG, then my patient could be having a heart block. So you want to remember that for the Nclex. If we have PR prolongation, so we're going to talk about what the normal should be, but if it's prolonged beyond normal, then you should be suspecting a heart block in your patient. Okay, so again, I'm going to try to recap all of what we've said so far, just to make sure we are on the same page. Okay, so we said when the SA node fires, we're going to have our first positive wave, which is our P wave. So again, when the SA node fires, you're going to have your first positive wave. When the atria contracts, we're going to have our first positive wave. And that's what we refer to as our P wave. Again, when we said when the current spreads from the SA node, it's going to go to the AV node, and the AV node is not going to allow the current to go into the ventricles immediately. The AV node is going to hold the current to allow for both atrias to empty their contents into the ventricle. And for that period that current is not moving within the heart, because the AV node is hiding the current, the needle of the ECG is going to go back to the isoelectric line. That's where you're going to have this portion, this flat portion of the ECG. And we say this represents our PR segment. So that's our first wave, and this is our first segment. We also talked about intervals, and we said if you add a wave and a segment, it's going to give you an interval. So if we add our P wave to our PR segment, we said it's going to give us our PR interval. And we said the PR interval starts from the beginning of the P wave to the beginning of the QRS complex. So we've added the two of them together, and that's our PR interval. And we said the PR interval represents the time taken for electrical activity to move between the atrias and into the ventricle. And we said there are times you would notice that the PR interval may be prolonged. And if we see a prolonged PR interval on the Nclex, you want to start suspecting that your patient might have a heart block. So that's for what all of the activities happening within the atria. Now let's go when the current moves into the ventricle. So now the current has gone from the AV node into the ventricle. Even though we're not going to break it down, but again, the ventricles depolarize in 3 stages. So you're going to have septal depolarization, which is going to give us our Q wave. And then we are going to have major ventricular depolarization, which is going to give us our R wave. And then we're going to have the final one, which is the basal depolarization, which is going to give you the S wave. But again, you can leave all of that and just know that all of the QRS complexes, the Q wave, the R wave, the S wave, all of it represents ventricular depolarization. All of it represents ventricular contraction. Again, we'll talk about what the normal should be when we are looking at our QRS complex, what we expect to see in a normal QRS complex. We'll talk about that. But again, just take note that your QRS complex represents ventricular depolarization or ventricular contraction. Okay, so again, after ventricular depolarization or ventricular contraction, we're going to have this period or this time interval when the ventricles have finished depolarizing. So now the ECG is not going to detect current moving within the ventricles again, because it has all transformed from negative to positive. So all of the myocytes within the ventricles are fully depolarized. So there's no current moving in the ventricles. And as a result, the needle is going to go back to the isoelectric line. And that isoelectric portion here is what we refer to as our ST segment. So this is what we refer to as our ST segment. Again, you want it to always be flat, because we said if the ST segment is elevated, it could be an indicator that a coronary vessel is occluded, and it's going to cause it to be elevated. So when I see ST segment elevation on the Nclex, I'm already suspecting a myocardial infarction in my patient. So there could be a total blockage of a coronary artery. That's why the ST segment is no longer flat. It is now elevated. You could also see it depressed. So instead of going up now, you see it going down below the isoelectric line. So we say it's depressed. We say the ST segment is depressed. And most times, when do you see this? You see it in clients with hypokalemia. So again, I've mentioned 3 very important information you must know for the Nclex. 1, when I see my PR interval prolonged, I'm suspecting a heart block in my patient. Number 2, if I see the ST segment elevated, I'm suspecting a myocardial infarction. And number 3, we said if the ST segment is depressed, we are suspecting hypokalemia in our patient. Okay, so after all of this depolarization, the ventricles begin to repolarize, and that's what gives us our T waves. So your T wave represents ventricular repolarization. So your T wave represents ventricular repolarization. Again, we also have our QT interval. Remember, we said intervals are made up of waves and segments. So if we add up all of these waves, add this wave, add this segment, all of it will give us our QT interval. So you can see the QT interval begins from the beginning of the QRS complex and it ends at the end of the T wave. So you can see it's kind of a summary of all the time taken for depolarization of the ventricles and also repolarization of the ventricle. So it kind of represents the total activities that is going on within the ventricle. So that's your QT interval. Is the time for depolarization plus the repolarization of the ventricle. That's your QT interval. Again, we would look at what the normal should be, but always remember on the Nclex, if I see a prolonged QT interval, if my QT interval is prolonged, what does it tell me? It could tell you your client has low calcium levels. Again, how do I remember my calcium levels? Cal, C-A-L, calcium, C-A-L. So when I see cal, I remember cal 911. So that tells me that my calcium level should be between, so instead of the 9, I remove 5, so that will be 8.5. And I remove 5 on the other side of the 11, so that will be 10.5. So my normal calcium level would be 8.5 to 10.5. Again, how do I remember it? I just think of cal, the cal in front of the calcium, cal. So that's cal 911. I remember that my calcium should be between 8.5 and 10.5. Again, if my client's calcium level is less than 8.5, the QT interval may be prolonged. There are other things that can also cause it, but again, that's one very important one you want to know for the Nclex. Okay, so again, if you have any question, you can drop it in the chat box. I'm going to try and move as slow as possible so that everybody's carried along. So we talked about the ECG drawing all of these waves and segments and all of that. But we need to know what the duration of each of these waves and segments is supposed to be. But again, you need to remember that on the ECG paper, you're going to have these tick lines. So see these tick lines, you're going to have them horizontally. So see another tick line here. This is another tick line here. So you can see it's thicker than this other one. And this is another tick line. You can also have them vertically. So you can see a tick line here. And this is another tick line here. So that's how you're going to see on your ECG graph paper. And within these tick lines, we have smaller boxes, small boxes that are formed from the lines that are not as thick as these other ones. And you're going to have 5 small boxes. So this is 1 small box, 2 small box, 3 small box, 4 small box, 5 small box. And then you have a tick line. It's 1, 2, 3, 4, 5. A tick line, 1, 2, 3, 4, 5, another tick line, and so on and so forth. So that's what you're going to see on your ECG graph paper. Again, there are just few numbers I need you to remember. Each of these small boxes, in terms of duration, each of these small boxes would take 0.04 seconds for the ECG to draw on this small box. So it's going to take 0.04 seconds if the ECG were to draw over this small box. Again, if the ECG were to draw from here to here, what do you think it would be? Obviously, it's going to be 0.04 seconds times the 5 small boxes. And that would be 0.2 seconds. Again, I repeat, this small box is 0.04 seconds. If I add it to this small box, it's going to give me what? 0.08. If I add it to this small box, it's going to give me 0.12. If I add it to this, it's going to give me 0.16. If I add it to another 0.04, it's going to give me 0.2 seconds. So that tells me that from one tick line to the other tick line measures 0.2 seconds. But again, just take note, just remember that one small box is 0.04 seconds. Okay, so now let's look at the waves and intervals. So one thing I want you to remember is that we said we're going to have our P wave, our QRS complex, our T wave, our PR segment, and all of that. Now, if somebody should ask you, how long in terms of duration should your P wave be? I just need you to remember this number, 2.5 or 2.5. So if somebody says, yes, the first positive wave is your P wave, how long should it be? All you need to remember is what? 2.5. So again, this is one small box, two small box, three small box, four small box, five small box. If they ask me, how long should your P wave be? I just respond and say 2.5. So let me draw my P wave. So I'm going to start here. So this one small box here, this two, and this should be half of this third box. And that's the duration for my P wave. So this is my P wave. Your P wave should be drawn over 2.5 small boxes. So again, remember, your P wave should be drawn over 2.5 small boxes. Now, if somebody should ask me, okay, after your P wave, the next one is your PR segment. How long should your PR segment be? Again, all you need to do is to remember this number. My PR segment should be drawn over 2.5 small boxes. So again, this is one small box here. This is two small boxes here. And this is the remaining half from this one. And that's where my PR segment should be, over 2.5 small boxes. So again, this is my PR segment. So you can see we've not done anything too complex. What's the normal duration for your P wave? 2.5 small boxes. What's the normal duration for your PR segment? 2.5 small boxes. Now, the next thing should be our QRS complex. So the next thing should be our QRS complex. Again, remember what we discussed earlier. We said our PR interval. So let me bring this up so that it's a bit clearer. Okay, so again, we've drawn our P wave and we've drawn our PR segment. And remember, we said from the beginning of the P wave to the beginning of the QRS complex is our PR interval. So it means that from here to here is our PR interval. And you notice that our PR interval is made up of what? 5 small boxes. So this is 1, 2, 3, 4, 5. If somebody asks me what should be the normal PR interval, all you need to tell the person is 5 small boxes. But because we said one small box is 0.04 seconds, you can as well say your PR interval should be 0.04 seconds times 5, which is what? 0.20 seconds. I repeat again, our P wave should be drawn over 2.5 small boxes. Our PR interval should be drawn over 2.5 small boxes. So if I add the 2.5 for my P wave to the 2.5 for my PR segment, it's going to give me 5 small boxes. And that's what makes up my PR interval. So if you add your P wave to your PR segment, that's your PR interval. And it should be drawn over 5 small boxes. Remember, in the previous slide, we said if our PR interval is prolonged, then it means our patient might be having a what? A heart block. So if we are saying our PR interval should be drawn over 5 small boxes, so automatically, anytime you see a PR interval that is more than 5 small boxes, then it means that PR interval is what? Is prolonged. And you can't be suspecting a heart block in your patient. So again, you don't need to cram so much all you need to know is that your P wave, 2.5 small boxes. Your PR segment, 2.5 small boxes. And because I know my P wave and my PR segment make up my PR interval, that tells me that both of them should not be more than 5 small boxes. 2.5 plus 2.5. So anytime I see my PR interval is more than 5 small boxes, I'm already thinking of what? Heart block in that patient. We'll talk about how to manage heart block subsequently. But again, you just need to know what the normal is. So my P wave, 2.5 small boxes. My PR segment, 2.5 small boxes. If I add up the two, that's my PR interval. That's 2.5 plus 2.5. And that should give me 5 small boxes. Again, the Nclex can tell you, the patient came in with a PR interval of 1.20. That tells me it's prolonged. It shouldn't be more than 0.04 times 5. It shouldn't be more than 0.20 seconds. My PR interval. So again, you can just write it down. Your PR interval should not be more than 5 small boxes, or it shouldn't be more than 0.20 seconds. So you can use boxes, you can use seconds, whichever is convenient for you. But again, you need to remember that your PR interval shouldn't be more than 5 small boxes or 0.20 seconds. So again, if your PR interval is prolonged, if it's more than 0.20 seconds, it tells you that maybe the AV node is holding the current for longer than necessary, or there's a slowing of conduction between the atria and the ventricle. So maybe there's the AV node, as a result of the AV node holding the current for too long. So you're suspecting maybe a 1st-degree heart block in your patient. Most times, medications like your beta blockers can also cause the patient to have a prolonged PR interval. So again, you want to look out for all of that. Okay, so now we've determined what our P wave should be, what our PR interval should be. Again, we said 2.5, P wave 2.5, PR interval 2.5. And if we add both of them, it shouldn't be more than 5 small boxes or 0.20 seconds. Now, the next online would be our QRS complex. Again, if they ask me, how long should your QRS complex be? The same thing. It shouldn't be more than what? 2.5 small boxes. So again, this is 1 box here, this is 2 boxes here, and this is half. So I'm just going to draw my Q wave here. I'm going to draw my S wave here, and then I can draw my arrow wave. Again, my QRS complex should not be more than 2.5 small boxes. So again, our QRS complex, we said, represents ventricular depolarization. It represents the ventricles depolarizing. Now, we always want our QRS complexes to be less than 2.5 small boxes. Most textbooks will go ahead and say, okay, it shouldn't be more than 3 small boxes. It should not be more than 3 small boxes. If it is more than 3 small boxes, then we are going to say that QRS complex is what? Wide. So again, I want you to remember that. If the QRS complex is more than 3 small boxes, then that's not what we want. We always want it to be less than 3 small boxes. If it's more than 3 small boxes, that QRS complex will be defined as being what? Wide. That's when you will hear it's a wide QRS complex. If it's more than 3 small boxes. If it's less than 3 small boxes, then we're going to say the QRS complex is what? Narrow. We always want the QRS complex to be narrow, because if the QRS complex is narrow, it tells us that the impulse followed the normal conduction pathway of the heart. That's why the QRS complex is narrow. It tells us the impulse came from above the ventricle. Most times you will hear supraventricular. Yes, because the impulse is coming from the AV node. It's coming from the SA node or from the AV node. It's coming from above the ventricles. But if the QRS complex is wide, it tells you the impulse may be coming from somewhere other than the normal conduction pathway of the heart. But again, how do I determine if the QRS complex is wide or narrow? Just by remembering 2.5. I always want my QRS complexes to be less than 2.5 small boxes. Or like I said, some textbooks will say 3 small boxes. Again, remember, if the impulse is coming from the normal conduction pathway, the normal electrical wiring of the heart, the QRS complex will be narrow. But if the impulse is coming from somewhere other than the normal conduction pathway, or maybe from an ectopic foci within the ventricles, our QRS complex is going to be what? Wide. It's going to be more than 3 small boxes. Okay. So now the next portion or the next part I will draw would be my QT interval. So the next part I'm going to draw is going to be my QT interval. Again, remember, if I come back here again, we said our QT interval starts from where? From the beginning of the Q wave to the end of the T wave. That's my QT interval. And one way I remember this is my P wave, I said, is 2.5 small boxes. My PR segment, we said, is what? 2.5 small boxes. So that's another 2.5. My QRS complex, we said, is what? 2.5 small boxes. So another 2.5 there, 2.5. If I add all of this, 5, 10, 15, 2, 4, 6, and then that's 7.5. If I add all of them, it gives me 7.5. If I add another 2.5 here, it gives me what? 10. And that's the duration for my QT interval. So again, P wave, P wave 2.5, PR segment 2.5, QRS complex 2.5. If I add all of them, it gives me 7.5. If I add another 2.5, it gives me 10. And that's the duration for my QT interval. So again, I'm going to start from here. Remember, your QT interval starts from the beginning of the Q wave. So I'm going to start from here, and I'm going to count 10 small boxes. So that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So I can start my T wave from here, and I'm going to add it to my QRS complex. So remember, this is my QT interval from here to here, and it should be drawn over what? 10 small boxes. Again, remember, we said the QT interval represents all of the activities that is going on in the ventricle. We said it's a time taken for the ventricles to depolarize and then for it to what? Repolarize again. And my QT interval should be drawn over 10 small boxes or 10 small squares. So those are the key numbers you need to know. Again, we haven't mentioned so many numbers. All we talked about was what? 2.5. We said our P wave should be drawn over 2.5 small boxes. Our PR interval should be drawn over 2.5 small boxes. Again, we said if the PR interval is prolonged, it means it's more than 5 small boxes, or it's more than 0.20 seconds. And that could signal a heart block in your patients. And then we went to our QRS complex, and we said we want to see our QRS complex narrow. Because if it's narrow, it means the impulse follows the normal conduction pathway of the heart. And we said we want it to be drawn over 2.5 small boxes. Or we mentioned that worst case scenario, it shouldn't be drawn over more than 3 small boxes. And then we talked about our QT interval, which we said represents all of the activities that are happening in the ventricles. And we said it should be drawn over 10 small boxes. Okay, just to be sure, everyone is paying attention. You can drop your answer in the chat box. Let's see what you think about this question. So the nurse is reviewing the ECG strip of a client with a history of myocardial infarction, and she notes that the PR intervals are 0.16 seconds. The nurse should arrive at which interpretation of this assessment data? So would you say this is a normal finding, or an abnormal finding, or an impending reinfarction, or a first-degree AV block? What do you think? You can drop your answers in the chat box. I'm going to give you 5 minutes to do that, and then we can proceed. A PR interval of 0.16. What will be your interpretation of this? Okay, so nice attempts. Again, remember we said our PR interval. So we said P wave, 2.5. PR segment, 2.5. And we said if we add the two of them together, it gives us what? Our PR interval. And again, if you add these two numbers together, what does it give you? It gives you 5 small boxes. So we want our PR interval to be it shouldn't be more than 5 small boxes. So again, if one small box is 0.04 seconds, 2 small boxes will be what? 0.08 seconds. 3 small boxes will be what? 0.12 seconds. 4 small boxes will be what? 0.16 seconds. And 5 small boxes will be what? 0.20 seconds. So again, this is what we want the range of our PR interval should be. It should be less than 0.20 seconds. Is 0.16 less than 0.20 seconds? Yes, it is. So automatically, that is a normal finding. That's a normal finding. We want our PR interval to be less than 5 small boxes. So if this patient has a PR interval of 0.16, it means his own PR interval maybe started from here and ended in the, sorry. So it ended in the 4th box here. And that's what would have given them 0.04 seconds, 0.16 seconds. Again, it's still within range, in as much as it is not more than 5 small boxes. We said if it's more than 5 small boxes, it's an abnormal finding. It means the patient may be having a first-degree AV block. But again, this patient PR interval is within 5 small boxes, or it's less than 5 small boxes. So this would be a normal finding. Okay, we just have 10 more minutes to go. Let's see how much we can cover. But again, I'm not even sure if this is recording. If not, you would have had the opportunity to go through it again once we are done. But I will check. I know it's streaming on YouTube. but I don't know if it's recording on YouTube, but I'll need to check after the class. Okay, so another thing I would like us to know when tackling ECG questions on the Nclex would be to determine the heart rate, because if you're able to determine the heart rate, you can actually say if the patient's heart rate is fast or if it is slow. There are different methods to use to, again, it's an estimate. It's not like it's going to give you an exact value, but again, it's an estimate. So there are different methods you can use. I'm going to show you maybe all three of them. But again, I would rather prefer you stick to one that you understand and you use that particular one so that you don't get confused using all three at the same time. So again, let's assume we have this ECG strip in front of us, and you are asked to determine the rates on the Nclex. So the first thing I'll need you to do is to memorize these numbers. I need you to memorize this number. The way I memorize it, I divide it so that it's easy for me to recite. And you will hear me say 300, 150, 100, 75, 60, 50. 300, 150, 100, 75, 60, 50. 300, 150, 100, 75, 60, 50. So again, I'm not going to go into breaking down why it is these particular numbers. All I need you to remember is these numbers. Now, the first thing you're going to do when you're trying to estimate the patient's heart rate is you're going to look for a QRS complex that falls on a thick line. So you're going to look for a QRS complex that falls on a thick line. So if we look at this, you would notice that this QRS complex falls on this thick line. Remember those thick lines we talked about previously? So you can see this falls on a thick line. Look at this QRS complex. It falls on the lights, those the ones that are not dark. So we won't be using this one. You want to pick a QRS complex that falls on any of these thick lines. So once you pick a QRS complex that falls on a thick line, those numbers that you memorize, I want you to start labeling all of those thick lines with those numbers. So remember, you're not labeling the one where you have the thick line or where the QRS complex falls on the thick line. You're going to go and start from the next one. And we're going to label this 300. We go to the next thick line, we label it what? 150. We go to the next thick line, we label it 100. The next thick line, 75. The next thick line, 60. And the next thick line, 50. Again, I repeat, we're going to pick a QRS complex that falls on a thick line, like this one here. It falls on a thick line. And then we'll go to the next thick line and start dropping those numbers that we memorized. So again, this thick line, we'll label it as 300. The next one, 150. The next one, 100. The next one, 75. The next one, 60. And the next one, 50. So all we need to do is to come back on our ECG and look for the next QRS complex as the next QRS complex after the one that fell on the thick line. So go forward, look for the next QRS complex, and it will be this one. Now, anywhere that QRS complex falls, look at the thick lines that are on both sides, and that will give you an estimate or a range of the patient's heart rate. So you can see this QRS complex fell between our 100 and 75. So that tells you that this patient's heart rate is between 100 and 75. So that's one way you can use to estimate the patient's heart rate. So again, pick a thick line that falls. Pick a QRS complex that falls on a thick line, and then label the subsequent thick lines as 300, 150, 100, 75, 60, 50. And look for the next QRS complex after the one that fell on the thick line. And wherever it falls, depending on our numbering, will give you an estimate of the patient's heart rate. So you can see if this is going to be 75 and this is 100, if we break it down, So this should be at about, so let's say here will be 80, and this should be about 85, 86 mark. Again, like I said, it's an estimate. Okay, so I'd like you to use the same formula and tell me what you think is the patient's heart rate on this reading. So again, like I said, this is already on a tick line, so you can use this. And what would you think? What does this patient's reading look like? What do you think the rate is? So I'm going to give you 5 minutes just to write your answers in the chat box. Okay, so again, we said we're going to pick a QRS complex that falls on a tick line, and this one falls nicely on a tick line. And we said we're going to go to the next tick line, and we're going to label it as what? 300. And then we said the next one will be what? 150. The next one will be what? 100, 75, 60, and 50. So this is almost falling on the 50 line. So we can actually say this is the heart rate is about 50, or if you still want to be exact, maybe about, so if this is 60, this is 50, this should be about 52 thereabouts. So it's at least if you said 50, you're right. If you said 52, you're still right. 54 would be maybe close to it. But like I said, it's not an exact, it's an estimate of the patient's heart rate, but at least getting 50 something tells us that this patient's rhythm is what? A bradycardic rhythm. So again, that's why it's very important that you are able to identify what the rate is. So this tells you this patient's heart rate is a bradycardic rhythm. Okay, just one more before we call it a day. How about this? What do you think the patient's heart rate is here? So again, you can see this doesn't fall on a tick line. This doesn't fall on a tick line. This doesn't fall. This doesn't, but this one falls nicely. This one also falls very well. This one falls perfectly well. So I can use this and then tell me what you think the heart rate is. Okay. Well done, everyone. So that's a good attempt. Okay, so again, like we mentioned, we said we're going to pick one that falls on a tick line, and then we'll go to the next line, and we're going to label it as what, 300. And the next one we're going to label as what, 150. And you can see that this one fell very nicely on the 150 mark. So again, we're going to call this rhythm a tachycardic rhythm. Okay, so just to recap all of what we did today, we looked at the ECG rhythm, looked at the origin of our P wave, our QRS complex, our T waves, and we looked at our intervals and the segments. We talked about what the duration should be, and we also looked at how we can calculate our rates. So like I said, we're going to be online for 1 hour. We're already at the 1 hour mark, had a very busy day today. I'll hopefully try to make out time and see how we can go into the other aspects. Again, I'm not in the habit of rushing my ECG classes so that I don't lose students along the way. So that's why even though we just covered only 8 slides, it still took an hour just to cover that. So again, hopefully I'll make out time and we can continue and we'll look at normal sinus rhythm. Once we're able to identify what the normal is, we can go forward to identify all those abnormal rhythms and how we can manage them. Okay, so on behalf of my team and myself, I would like to say thank you everybody for joining and just stay in touch in the group. And would also always publicize a new date for our next classes. So thank you very much and we'll have a good night's rest.